Hello, everyone, and thank you for tuning in to Help for HD TV. Today, we have Genentech on with us to talk about our Generation HD2. There has been so much talk in our community after the news from Generation HD1 came out, and we really want to come on and break down some of the stuff that's been talked about that has changed after all the data has been reviewed and looked at. Also, talk about why they moved forward into a new trial and break down some of the stuff going on around the community. So we have a clearer understanding of Generation HD2 and we feel more comfortable with it as community. We have Dr. Gandhi on with us. Rita, some of you have seen her speak at our live event. She's awesome. I'm so glad she's here. And then we have Dr. McColgan on with us today. So let's just start by you guys telling us a little bit about yourself and how you guys have been involved in HD.
I'll get started and then I'll pass it on to Peter. Dr. McColgan, just a little bit about me. My name is Rita Gandhi, as Katie said, and I'm a movement disorder neurologist, practiced in the United States for a period of time. I practice in a small community in West Virginia called Huntington, West Virginia, where I had a chance to really see a lot of Parkinson's as well as Huntington's disease patients. So I'm excited to be here, and I'll pass it to Dr. McColgan.
Thanks, Rita. So I've been working in HD for more than 10 years now. I'm a neurologist as well. I have been working in the UCL Huntington's Disease Center since 2012. I did my PhD there. I still see patients here. And I moved over to Roche a couple of years ago because I wanted to get more involved in trying to find treatments.
So with Tominersen being the first treatment or attempted treatment for the cause of Huntington's disease, without it being like a symptom treatment. How does it work? How is it different from other types of treatments for HD? And we'll go ahead and start with you, Dr. McColgan.
So it's a great question. The treatments we use in the clinic currently are symptomatic treatments. So they can help the symptoms of HD, but they can't treat the underlying cause. With treatments like Tominersen, we're aiming to tackle the underlying cause, which is the mutant huntingtin protein. And we've been able to show with Tominersen that we can lower the mutant huntingtin protein in the CSF. And we hope going forward with the new study that by lowering that protein, we'll be able to see some clinical benefit. How the drug works is it targets the protein, and we deliver the drug by doing a lumbar puncture, what's also known as a spinal tap. And the reason we do this is we can get the drug where it needs to be in the brain. And we have data, and we've shared data before, that we can get the drug to the areas of the brain that are most affected in HD.
We were able to learn a lot about this over the years involved with Genentech and Generation 1. Everyone was devastated when we got the news about Generation 1. Rita, if you can talk to us a little bit about maybe what happened with Generation HD1 after you have looked over all this data for so long, and why do we now have a Generation HD2 study?
Yeah, thank you, Katie. I'm really excited to be able to talk about this because I know there's a lot of questions about it. What we realized after we looked at Generation HD1 was that the dose was too high in the participants that were getting 120 milligrams every 8 weeks or every 2 months. And that led to that group having a faster progression. And in those participants that were on 120 milligrams every 16 weeks or every 4 months, they progressed the same as those without the drug. Looking at all the information, so all the data that wasn't necessarily related to just the endpoints, we found a potential benefit in a younger, less advanced HD population. And the reason why we think that group may have been able to do as well is because they were able to tolerate that dose and potentially the medication a little bit better. As a result, we're focusing on this group and we're using a lower dose to see if we can replicate that benefit that we saw in the study. And our goal is to eventually expand this group into a wider group as we look forward into a potential next study if we do see a signal.
Fantastic. So it's so funny. We always think more is better, right? If we take more Tylenol, then we get a fast. It's so interesting that some cases this shows more was not better. And I actually, this is not the first trial I've heard that from in HD, that they have actually found the lower doses have been more beneficial. So Katrina, I'll hand it over to you, but that's what I got from that whole talk. Is that right?
Absolutely. And I think just moving forward, as we start thinking about medication, like you said, there are a number of medications that are used in other disease areas, like in cancer or even for pain. And Tylenol is a great example of that. So when you take Tylenol, you take 500 milligrams, it helps your pain. But if you take 4 grams of Tylenol, it causes liver failure. And so often we forget those things that yes, the Q8 group did show that those patients did progress faster. But if we look at Q16, those patients didn't. They actually were at the same as placebo. And as we move forward and we collect more data, we're hoping that we can continue to see more potential benefits that we see with some of the other biomarkers, but also by looking at this dose at Q16, what we've seen so far is that in this Q16 populations, there's nothing that makes us concerned to not go ahead and use it in further clinical trials.
Thank you. So, Dr. McColgan, as Katie mentioned, this was quite devastating to the HD community. And Dr. Gandhi went over some of the different data analysis. But what do we know now as far as lasting effects or benefits?
In terms of lasting effects, what we did when the dosing was stopped in Generation HD1, we continued to assess people, and so they continued to come in for visits, and we did assessments and blood draws and lumbar punctures. And because of the commitment and dedication of those individuals on the trial to keep coming in, we were able to understand not only what happened in the doses that we had in Generation HD1, but what happens when you stop the doses. And so we were able to see, and this is some of the data that we shared at CHDI in February, when you look at biomarkers. So when I say a biomarker, it's something that you can measure in, for example, blood. So we looked at a protein called neurofilament light, and that's a protein that goes up over the course of Huntington's disease, and that's usually a bad thing. But what we saw when we looked at people in Generation HD1 is at the treatment every 16 weeks, that began to go below placebo at the later time points on the study. It went below placebo when people were on treatment, but also when people were off treatment at those later points as well. So that suggests that, and again, with what Rita said, this idea of potential benefit, if we're seeing NFL go down, which is thought of as a good thing, and we see the sign of potential benefit, at least in these individuals who are younger, that gives us hope that we may see benefit moving forward in Generation HD2, particularly at the lower doses that we're looking at in the study.
Yeah.
That's a huge point about the NFL, because this is what we heard from the beginning of Generation 1. There was a couple doctors that were saying, like, NFL, look at this. And it was like, so that kind of scared people right off the bat, right? And so to hear the NFL actually went below placebo, that's a huge point. Everyone needs to know that, because that was a big fear for the community, was this NFL.
One thing I was going to add, and this is why it's so important for us to do Generation HD2, because we want to replicate that. We want to continue to show that. And so bringing people into the study is very important, because our initial study wasn't necessarily powered for this smaller group. And so we need to be able to show that's truly a true signal that there is this potential benefit that can be seen.
Sure. I could see that. I think we'll probably make this point a lot to our community throughout this show, is that we won't know unless we show up, because this was a very small population that they looked at in Generation HD1. So they have to look at, obviously, to meet the FDA requirements, they have to look at more of us in a larger population to see if this really truly is a benefit signal that they're seeing in this population. And this is a population that doesn't really show up for clinical trials as much, and isn't used to being in clinical trials or being allowed to be in clinical trials. So this is a new thing for us, and we definitely, this is going to be one we're going to have to show up for. It's what we've been asking for a long time.
And to that point, we really designed Generation HD2 with younger individuals in mind. We were very mindful of the fact that people might have childcare responsibilities, they might be in work, so we have less visits, we have less lumbar punctures, we have less assessments on the day. So we really designed it to try and be much more streamlined and flexible for taking all of that into account.
Fantastic. I did not realize that. So that's a huge, so let's talk about that a little bit. Let's talk about the difference maybe a little bit between HD1 and HD2.
Sure, I'm happy to do that. As Dr. McColgan was mentioning, the biggest differences between generation HD1 and 2 is that we have a lower dose. So we're looking at 60 and 100 milligrams every Q16 weeks, and this lower frequency as well, as we mentioned. So not only is it the lower dose, but lower frequency of Q16. And this lower frequency also means a lower number of spinal taps. So there'll be about 5 in the first year and then 3 in the second year. It's also a smaller study. Currently, we're looking at about 360 patients versus the 791 patients that we had in Generation HD1, and a smaller length size, so length of the study. So it'll be a 16-month study with a common closed design, which means all patients will be in the study until the last person's last visit, which will be different than Generation HD1, which was a 21-month study, and fewer clinic visits. So we have about 8 versus the 25 we had in Generation HD1, as well as fewer assessments. And we're not including any digital assessments as well, because again, we want it to be less burdensome. And so our goal is to really be thinking about, as these patients are younger and as they have to come in for their visits and the care that they may need with their family and such, our goal was to try to make it as helpful as we could to the patient community. But I do want to talk also a little bit about how the drug gets into the brain. It is delivered via a spinal tap. And so that allows the medication or the Tominersen to get into the areas of the brain that is most effective. And as we know, it's one of the only drugs that's shown to lower mutant Huntington protein. So the goal is to get it into the right area of the brain and to lower that protein. And one of the things that we talked about is our data. So it is shown to be safe at Q16 weeks as we give it every 4 months, because we're lowering the dose. In addition, one of the main areas that we wanted to address as well as our study. And then, as Peter talked about too, this data now that's showing that NFL results as well, showing that there is a potential for it to be going below placebo. We want to be able to replicate all of that and show some of that evidence as well.
So apologies, Katie was having some technical difficulties. So we 3 will finish the show off, and we're going to just jump right into the next question. For Dr. McColgan. In the community, it's been said that Generation HD1 was shut down for safety concerns. But what changed, or is that true? And what changed with Generation HD2 to provide participants with a safer experience?
So that's a great question. Let me try and address it. What happened in Generation HD1 is we had 3 groups. One group who didn't get a treatment, that's called the placebo group. One group who had 120 milligrams of Tominersen every 8 weeks, and one group who had 120 milligrams of Tominersen every 16 weeks. So what we saw in the people getting the more frequent dosing regimen is that they began to do worse than people that weren't getting drug. And that was picked up by our independent data monitoring committee. And when they saw that, they recommended that we stop the study. And so, of course, we followed that recommendation, and the dosing was stopped, but we began to follow people up after they stopped the dosing to see how they did. In Generation HD2, we're only treating people every 16 weeks. So we're not treating people as frequently as the group who did worse in Generation HD1. The other thing to say is we're looking at lower doses. We were worried that in Generation HD1, and those people getting the most frequent dose, the dose was too high. So we're looking at lower doses at a lower frequency than the people that didn't do so well in Generation HD1. And we're also looking at a subgroup of individuals. One of the concerns as well is that the older individuals in Generation HD1 at that more frequent dose maybe didn't tolerate things as well. With Generation HD2, we're looking at younger individuals with lower doses in the hope that we can show benefit. And if we're able to show benefit, then we want to look at trying to expand to try and treat as many people as possible. And that would be at hopefully older age groups in future studies. But we have to first see if we can show benefit in Generation HD2.
Great, thank you. And Dr. Gandhi, the difference between Generation HD1 and Generation HD2, one of the big differences is that people who are gene positive, but in the very early prodromal stages, are now eligible. Can you go into the prodromal stage and why this is such a big deal?
I think one of the things that we kept hearing from the patients groups and also following just the science is that the need for studies to start looking at earlier groups, earlier populations. As we know, manifest is a little bit of a later group. So we really wanted to develop a study looking at earlier participants in mind. And while the prodromal group is an important part, I think, of the study, I just want to keep in mind that it's only really a fifth of the people that we're looking at. We're really looking at more sort of early manifest with also looking at some prodromal. But that in mind, when we think about prodromal patients, those are really individuals that have very mild motor abnormalities or are functionally independent. Whereas as we look at early manifest, those patients are also, they tend to be earlier, but they tend to have more motor manifestations and aren't as necessarily as independent as those prodromal folks. So that's how we look at it in our study. But I think it's important because I think not only just on our study, but other studies that are coming in, we're going to be looking at that earlier and earlier population, and trying to reach out to them is very important, as we hear that a lot of times patients aren't necessarily in clinic seeing a neurologist. And so as that earlier group comes out and they're starting to develop more abnormalities, they may or may not be seeing Huntington's physicians or neurologists in general, but we want to keep them in mind and let them know that there are studies like ours that are looking to enroll them and be able to study them and see if we can find potential treatments.
So let's go back to you, Dr. McColgan. In the HD community, there's been talk about if you participate in this particular clinical trial, that you are then receiving a diagnosis of HD, that you have then been told you have HD. Is this true? And what does that mean for those patients participating?
I think the first thing I would say is that I don't think the diagnosis of HD should be made in a clinical trial setting in any circumstance. So I think the diagnosis of HD has to be made with your physician, and when your physician is seeing you in their clinic. And of course, it has to be done in a sensitive way. And a clinical trial is not the environment to do that by any means. Specifically for Generation HD2, you don't need a diagnosis of HD. And when I say a diagnosis of HD, a diagnosis of manifest HD. When we think about if people have motor signs of HD, that's how it's traditionally diagnosed. So to take part in Generation HD2, you don't need that diagnosis of manifest HD. So we're recruiting participants who have a diagnosis of manifest HD, but of course we're recruiting participants who also have prodromal HD. So that when I say prodromal, that's when people have really early subtle signs that may only be detected by your neurologist. So you don't need a diagnosis of HD to take part in the study.
Great, that's very clear. Thank you. And Dr. Gandhi, can we just go over something that I know everyone is always most interested in, when that's the inclusion exclusion of any trial, but specifically let's talk about what we're doing with Generation HD2.
Sure. I think there's some key components that are really important, and I don't want to highlight all of them just because I think there's a lot. And so I like to go over some of the basic stuff. And then I think importantly, it's just important no matter whatever clinical trial you're doing, that you want to talk to your HD physician, or even just call the TISL, or the information we'll give you to understand more about the trial. But if we think about some of the key inclusion criteria, one is we're looking for patients that are between the ages of 25 and 50. And as Peter mentioned, as we talked about earlier, people that are within that prodromal or early manifest groups are the ones that we're really looking at. And then obviously, if you've been in the previous Generation HD1 study and you had study drug, you can't necessarily be in our study. But if you were in Generation HD1 and you were in part of that placebo group or that no treatment group, you absolutely, and you fit the criteria, then you can be in our study. But I would just say other things just to remember is, no matter what, talk to your HD clinician or your physician about the study and go over the criteria with them to see if it's something that could be good for you, and not only just in our study, but for any studies. I think that's important.
Dr. McColgan, can people who participate in Generation HD2 participate in other clinical trials after this one has been completed?
It's a great question. I think the first thing to say is that if other companies are running trials, then It's really not up to us or for us to say what their inclusion criteria will be. What I can say is that, just speaking generally, some studies may allow you to take part, even if you've been in a prior study, as long as there's been an interval period where it would be sufficient for the previous drug you're on to be out of your system. So that's called the washout period. It may be in some instances that if you wait 5 weeks or 6 months or even a year between trials, then there's a sufficient amount of time for that previous drug to get out of your system for you to join another trial. And that's typically what happens, but it's difficult to speak about specific scenarios because it really depends on the person who's designing the trial, on what they want to do.
On that, definitely reach out to whatever trial you're interested in next and get their information. And I'm sure there can be some sort of conversations that can happen, and you can find out your answers through them. But why don't we go ahead and wrap up with that and just let us know, Dr. Gandhi, where people can go to find out more information about this clinical trial and how they can participate.
Thank you, Katrina. So I think number one, if you're interested in this clinical trial, please reach out to your Huntington's disease physician or clinician to learn more about it. But you can also go to our Genentech trial site. It's Genentech Trial Information Support Line, also known as the TISA line. And I can give you the number, I'll just say it out loud, but it's 888-662-6728, and they are open Monday through Friday, 5 a.m. to 5 p.m. Pacific Standard. And again, that what we call the Genentech Trial Information Support Line is 1-800-662-6728. The other thing they can do is go to clinicaltrials.gov, and all of the study information is posted there, and you can get information on where the different studies are. But the TISA line can also help you figure out where the nearest site is for you.
Great. And that's super helpful. As you all are watching this show, I'm sure there's a lot of questions that come up once you hear all the information and you wonder if you can participate. And it's great to talk to your doctor. But if you have specific questions about the trial, please take advantage of this line. It's so important that you guys get the right information versus kind of listening to what everyone hears online. I think this is where you're going to get your facts and you're going to be able to understand what's the most current information. Do you both have any final thoughts for us today on any of it, on any of the trial information or for the community?
I think one is we just wanted to say thank you to the community, because I know there were a lot of people who are in Generation HD1, and that data has really helped to inform us as we move forward in Generation HD2. But I also want to just say how important it is for us to do this study and to really see if there is this continual potential benefit as we're moving forward. Because I think treatments in Huntington's disease, there's been a lot of disappointment, and I know it's been difficult, but I think there are some potential benefits that we can see, and we want to be able to move drugs that will help the community forward.
I think I'd echo Rita's comments, and a massive thank you to the HD community. Without all their hard work and commitment and dedication over the years and going forward, we wouldn't be able to do what we do. Massive thank you.
Absolutely. And again, I'm going to say it too. Thank you. You guys are really helping progress medicine. And on that note, I just want to say thank you both for coming and working through all of our technical difficulties. And for everyone watching, please don't forget to this video, subscribe to our channel, and ring the bell for when more shows like this come out. We'll see you next time.